In today's edition of From the Newsroom, we have with us Malia Politzer. Welcome to the show, Malia.
Thank you.
We're also joined by Dr. Sarabjit Chadda over the phone. Welcome, Dr. Chadda.
Thank you.
In today's edition, we'll be talking about the increasing number of cases of multi-drug resistant tuberculosis in India and how the migrant labor population is particularly vulnerable to this disease. So, Dr. Chadda, if you could tell us, how does someone get MDR TB and why is it so difficult to cure?
The main reason for getting a drug-resistant TB or multi-drug resistant TB is that the bacteria which causes tuberculosis is becoming resistant to two common drugs which are most effective in treatment for the disease. The main reason is irregular treatment or incomplete treatment. Now, as the disease requires 6 to 8 months of treatment, which is pretty long, considering or comparing it with any other infection, patients tend to stop the treatment midway. And since most of the patients, especially the poor ones, cannot afford the treatment, and if they are making out-of-pocket expenditure for this treatment, the chances of their completing the treatment to the end become less.
Malia, tell us why migrant laborers particularly at risk of developing MDR tuberculosis.
It's not so much that they're particularly at risk for developing it, but they're particularly vulnerable to the disease. The problem with migrant laborers is in general they're the poorest of the poor, and because they move around so much, they're oftentimes missed by any public healthcare scheme at all, let alone tuberculosis. And of course, tuberculosis treatment regimes are very long. For MDR TB, it can be 2 to 3 years. For normal TB, it's 6 months. So if they start treatment, and then after 3 months later they have to go someplace else for work, and then they stop treatment, then they're at much higher risk of developing multi-drug resistant tuberculosis. The other problem with migrant laborers is also getting them into the system in the first place. Oftentimes, they won't necessarily seek healthcare because they're afraid of A, missing work, and also because they can't afford it. So even if they do have a lot of the symptoms of tuberculosis, they're at a much higher risk of never making it into the system in the first place.
Dr. Chadda, how big is the risk of MDR TB and what is at stake here?
If you look at the statistics which come from a prevalence survey, in India, the prevalence of MDR TB is quite low. Amongst the new cases of tuberculosis, that is those cases who have never had tuberculosis in the past, the prevalence of MDR is less than 3%. Whereas in those cases which have had treatment for TB in the past, which we call as retreatment cases, the prevalence goes up significantly to about 12 to 15%. However, again, like I said before, the main reason for developing drug-resistant TB is irregular or incomplete treatment. Normally, if you look at the statistics, out of 100, only 3 patients would actually be suffering from MDR TB. The rest 97 would get cured completely if they took their treatment properly and regularly.
Malia, what are the approaches that are actually working in this field?
Well, I think there are a number of approaches that are working, but some of the really innovative models that have been piloted by NGOs in partnership with the government include one that's very interesting by an organization called Operation Asha, and they're training, they work in South Delhi and also in a lot of the communities outside of Delhi, and they've trained healthcare workers who are actually proactively go to try to find new TB cases out in the communities in areas where people wouldn't generally be seeking treatment. So that's a way that they're trying to reach communities that otherwise would be totally missed, rather than the current program, which, although there are healthcare workers that do monitor treatment, they're not necessarily proactive about looking for it. They kind of rely on people to come into the system. But the problem with, for example, migrant laborers is they might not ever get into the system, so this is quite a proactive approach. And then the other approach, which is very interesting, is the use of technology. They've started looking at how to use biometrics. Because one of the problems, of course, even if you use community healthcare workers, it's only a tick on a box. So a healthcare worker, for whatever reason, could say that somebody's received treatment when they haven't. But if you use biometrics and every time they take a pill, or whatever the treatment is, they have to take the fingerprint, then you can't fake that. So that sends, if there's a missed treatment, then it sends a SMS to a central location, and they know that somebody's missed out on treatment, and they can proactively go look for that person.
So thank you, Dr. Chadda, and thank you, Malia, for being on this show and shedding light on how MDR tuberculosis can actually be cured and prevented. On this note, we'd like to end today's show. Thank you and stay tuned.